So let's start the scientific presentation now. We have 7 speakers for oral presentation. The first speaker is from Tübingen University, and her talk is about identifying causal factors for thoracic aortic morphology using non-contrast enhanced MRI proof of concept on a large epidemiological imaging study. Luisa? Yeah, please, thank you.
Thank you for the introduction. Hey everyone, I'm Lisa Fay, and I'm currently doing my PhD at the University Hospital in Tübingen, and I'm really happy to share our work today. So in our work, we used a large amount of non-contrast enhanced MRA images to identify factors that actually causally influence the morphology of the thoracic aorta. So this work is motivated by the problem that changes of the thoracic aorta are often remain undetected and therefore may lead to life-threatening risks such as aneurysms, as we all know. And we want to find out now which factors actually causally influence the shape of the thoracic aorta. Previous studies, they rarely had access to a large amount of non-contrast MRA images or MRA in general. So they could only focus on the relationship between healthy subject and subject with an aneurysm, but they could not really figure out which factors already lead to changes of the thoracic aorta. And moreover, they mostly focused on relationships or the association between factors that lead to an aneurysm, but without incorporating possible confounds in the data set and without exploring the causal influences. And with our work, we try to fill those gaps, so we use a large amount of non-contrast enhanced MRA images to train a deep learning model and perform an automated shape analysis of the thoracic aorta, and then we take those results in the second step and perform causal analysis to find out what actually leads to changes in the thoracic aorta. So in the first step of our work, we trained a deep learning model and therefore used the non-contrast enhanced MRA images, and the output of our deep learning model is not only the segmentation mask, but additionally 6 landmark points. And having those landmark points, we could divide the thoracic aorta in its 3 main components, so the ascending and the descending part and the aortic arc. And having those results, we then could also automatically compute the center line of the vessel, and with this as well, the length, the volume, and the diameter size. And for our upcoming analysis, we used the diameter size of the mid-ascending aorta to find out which factors actually lead to changes in the thoracic aorta, and we could just compute this automatically then. And since we wanted to figure out now what factors actually lead to the changes in the thoracic aorta, we first performed standard statistical tests. But as I already mentioned, we wanted to find out the real causal relationships, and therefore we also performed Peter-Clark algorithm. And Peter-Clark algorithm outputs a causal graph, so it shows basically the causal relationship between single variables, and it's based on the common cause principle. So common cause principle basically states that if we have a common cause that influences 2 variables, those 2 variables are independent. So to give a bit more hands-on example, so if we observe, for example, an increase in ice cream consumption, and at the same time we observe an increase in sunburns, we would not conclude that eating ice cream would lead to a sunburn or the other way around. But as we all know, there exists a common cause, or also known as confounder, which influences both variables and makes them independent. So the relationship between ice cream consumption and sunburns is spurious. And this is exactly what we want to do in our work. So we want to find out which factors actually causally influence the diameter size of the thoracic aorta without being fooled by any spurious correlations. And we performed this methods on the German national cohort, and this data set is so special since we had access to almost 11,000 non-contrast enhanced MRA images, and additionally approximately 250 different metadata. So in the first step of our work, we took those non-contrast enhanced MRAs and trained our deep learning model, and also then could compute automatically the diameter size of the mid-ascending aorta. And then for the second step of the work, we chose some metadata variables, and therefore we decided to use the sex, age, height, weight, and the alcohol consumption of the subjects. And then we wanted to find out which of those factors influence the diameter size of the thoracic aorta and how they are related. And with this, I'd like to share our findings. So as I mentioned, we first performed those standard statistical tests to just get an insight how the variables are correlated. And we found that the sex of a subject is related to the diameter size, because males have in general higher diameter size as females. We could also observe a moderate correlation between age, height, and weight, and the diameter size. And for the alcohol consumption, so alcohol consumption was grouped in 6 categories, from drinking never to drinking daily. And we could also observe there that, like, with an increasing alcohol consumption, also the diameter size of the theoretical aorta seems to enlarge. And having those correlation results, we could now set up our hypothesis for the causal analysis. And therefore, we hypothesized that the diameter size of the theoretical aorta is causally dependent on sex, age, height, weight, and the alcohol consumption. So we would expect from the Peter-Clark algorithm to output the following causal graph. So where all those variables shown with the blue arrow actually causally influence the diameter size, but then additionally we also have like some causal relationship between the single variables, since, for example, sex influences the height of the subject. However, when performing Peter-Clark algorithm, this is what we got. And compared to our presumed graph, this is not exactly the same, since we had like presumed that we will have a causal relationship between the alcohol consumption and the diameter size. But Peter-Clark algorithm didn't get that result. So this seems to be a clear indication that there might be a spurious correlation between the alcohol consumption and the diameter size. And now to figure out why those two variables are actually independent, we checked on the single groups of alcohol consumption, and therefore I like to share you the findings between the group of drinking never and drinking daily. So what we could observe that in our data set, people who drink daily alcohol are generally older, they are taller, and they are heavier. And as we figured out before, like with the correlation test, but also as Peter-Clark algorithm revealed, if those factors increase, also the diameter size increases. So we could we found that those factors actually are a confounding factor for the relationship between the alcohol consumption and the diameter size. So we simply only have a spurious correlation between the alcohol consumption and the diameter size, and not like a causal relationship. And with these results, we have to reject our hypothesis, since only sex, age, height, and weight causally influence the diameter size of the thoracic aorta, while alcohol consumption is only spuriously correlated with the diameter size. So we can conclude that it's really important to figure out if we have like spurious correlations in our data sets, since they could basically exist in any kind of data set. And in our upcoming work, we like to extend our analysis. So now we used 11,000 data sets, but we have access to 30,000. So we want to extend our work to that, and then also perform find out like which more factors which influence the thoracic aorta, and then additionally we have also access to the abdominal aorta, so we want to extend the study to that as well. And yeah, with this I'd like to thank my colleagues and my supervisors for the great support and for your attention. Thank you.
It's a very interesting work. And any questions?
Thank you for a great talk. I had a question about the training and testing of your deep learning algorithm. I'm assuming you kind of had to manually label or segment and label some data sets.
Yeah.
And then, the question is, of these 11,000 data sets, how many were actually used for training your algorithm?
Yeah.
And then the second question is, did you do any validation on the diameters you get from the automated calculation versus a manual measurement by a radiologist?
Yes, so we had 2 radiologists who first did the labeling of the data, and we trained our model on 70 data sets, and then we evaluated on 30 data sets. So that was we had 100 data sets where we had a real ground truth, and for the other 11,000 we did not have a ground truth, but we had a radiologist who went through all the results to check is the segmentation mask respond does it make sense, the segmentation mask as we have it, and also does the landmark points we detected make sense, so that we could be sure that our automatic computation of the diameter size makes sense in the end.
Thank you.
Sure, thank you.
It's very interesting. You had a huge data set of 11,000. There's not many published data actually on the size of the thoracic aorta that is stratified by age and gender and body size. Are you going to publish the normals as a normal range for us to use?
So you mean the data set, or?
Yeah, just the ranges that you found, because in the published literature, there's the numbers are not that large for actually measuring the aorta in normal people.
Yes, we will do a publication on that. So there already exists one, but it's only on the 100 data sets, but we will now do a publication on the 30,000 data sets, so with all the ranges of all the variables.
Thank you.
So nice talk. I have a question about your centerline algorithm extraction, centerline extraction algorithm. So I was wondering how robust is centerline, what algorithm you use. If you elaborate on that, I really appreciate that. And my second question is that how it's, like robust to the, let's say, noising your segmentation results.
Mhm.
Thank you.
Thank you. So regarding the centerline detection, so this method is based on the fast marching algorithm. And so basically what we do, we have a source of our, a source point and an endpoint, which we use by the landmark points. And then with these fast marching algorithm, we could get the travel time in each point of our image. And so then we take the gradient of this image and take the direction of the smallest gradient to get the fastest travel line, and that's how we could extract the center line. And regarding the second question, can you just repeat it? I'm sorry, I forgot it.
How robust it is?
Yeah.
Segmentation.
Yeah. Actually, the segmentation is quite good. So sometimes what we could see, if there's some other vessel connected to the thoracic aorta, then we could sometimes see that also have this part on the segmentation mask. But we could also do some post-processing to get rid of that. So the segmentation is actually pretty good.
Thank you.
Yeah, sure. You're welcome.
Maybe a short question.
Yeah, it's very interesting study. So this is a cross-section design. You're trying to investigate the causality effect. I wonder if you have some genetic measurements for your data set?
And what kind, for example?
Like a genetic.
Yeah, I don't think we have that. We just have things like vascular stiffness and stuff like that, which we will use for the further analysis.
Yeah. Let's move on to the next session. Thank you again.
The next speaker is Tarun Narain, and he will talk about quantifying differences in aortic pulse wave velocity across the respiratory cycle.
All right, hello, and thank you for the introduction. So let's just jump right in. So a little background, pulse wave velocity is a measurement of the speed at which blood pressure waves propagate through a vessel. There's an inverse relationship between pulse wave velocity and arterial stiffness, and arterial stiffness has been linked to certain cardiovascular pathologies. Therefore, pulse wave velocity is an important and highly validated biomarker for early cardiovascular pathologies, and there's high demand for more accurate pulse wave velocity measurements. So, MRI has been explored as an option for accurate, non-invasive pulse wave velocity measurements. With MRI, we can measure blood flow at multiple points along the vessel and calculate the distance and time shifts of the flow curves between those points, which gives us the pulse wave velocity. So this project comes about as part of the LIFE study. Essentially, we wish to assess how lifestyle and fitness levels influence Alzheimer's disease in at-risk individuals. We have 150 subjects undergoing exercise studies and are obtaining MRI data in the brain and aorta, along with many other exercise-related parameters. We wish to measure pulse wave velocity using phase contrast imaging in our elderly subjects to characterize their cardiovascular fitness. Now, clinically, breath holds are the standard for acquiring phase contrast images. However, elderly subjects and those with Alzheimer's can have great difficulty in performing long breath holds on command in the scanner. That's why our group recently introduced a free-breathing, radially sampled, retrospectively gated 2D phase contrast sequence. This allows us to measure pulse wave velocity in Alzheimer's patients without breath holds. It also affords us flexibility in reconstructing images at different respiratory states and allows us to explore the clinically relevant information that might be in the delta between them. So for our study, we acquired 2 sets of data per subject. First, we acquired ungated high-resolution Fiesta images in the axial, coronal, and sagittal directions so that we could use to segment a 3D aortic center line. We then acquired our free-breathing radial sequence, and we acquired 2 axial slices, one in the aortic arch and one in the abdominal aorta. So this gives us 3 total cross-sections of the aorta. We also acquired pulse oximeter and respiratory bellows data throughout the acquisition so that we could use in retrospective cardiac and respiratory gating. All of our subjects were scanned on a 3 Tesla clinical system with an 8-channel cardiac coil. Unfortunately, data from 40 of these subjects had to be discarded due to poor image and gating quality. So to analyze our data, we have this custom analysis tool written in MATLAB by my co-author, Grant Roberts. First, it pre-processes our reconstructed images. And then next, it guides a user through tracing an aortic center line in the Fiesta images by placing points in both the sagittal and axial views. And so this generates our vessel path lengths. Next, we segment the ROIs into 2D phase contrast data, and the tool will generate flow curves for each of the ROIs. It also will do the flow curves are smooth with the Gaussian filter for easier analysis. And then finally, we calculate a global aortic pulse wave velocity. So how exactly do we calculate that pulse wave velocity? Well, the formula is fairly simple. We just divide the vessel path length by the flow curve time shift. We can easily get the path length from the 3D center line. The time shift is a little bit more, or a little less straightforward. So what we want to do is we want to calculate the delay between the flow waveforms. But there are actually multiple ways to do that. We actually implemented multiple of the most, or like 4 of the most popular time shift algorithms: time to point, time to foot, time to upstroke, and cross correlation. And each of these has their strengths and weaknesses, and there's no clear gold standard amongst them. For our analysis in this one, we selected time to foot as our most robust method to report our results with. So a little breakdown. In the time to foot method, what we do is we fit a line to the upstroke of the flow curves, and then we extrapolate that line down to the baseline, and the difference between the x-intercepts is our delta t. And so once we do that, we plot the change in distance versus the change in time for each of these points, and we fit a line to that, and the slope of that line is our global pulse wave velocity. So here are our results. We calculated a global pulse wave velocity for 90 subjects in both expiration and inspiration. So why only 90 of the 110 good data sets we had? Well, the additional 20 were excluded due to the failure of the TTF algorithm to produce physiologically feasible values on those subjects. So like values that were like in the hundreds or negative. This is an issue we had with each of the algorithms we tested, where they would fail on certain subjects, but to go into that would take more time than I have. So in these 90 subjects we noticed a significant decrease in mean pulse wave velocity between expiration and inspiration of around 14%. And when comparing across age, we saw that pulse wave velocity generally increases with age, indicating increased arterial stiffness. We also see that pulse wave velocity calculated in expiration remains consistently higher than pulse wave velocity in inspiration. So in conclusion, we were able to successfully measure pulse wave velocity in a large cohort of subjects at risk for Alzheimer's disease using a free-breathing, radially sampled 2D phase contrast sequence. We saw a significant difference between expiration and inspiration, which is consistent with reported results in the carotid radial artery. Additionally, we saw a positive correlation of pulse wave velocity with age, indicating increased cardiovascular risk, which we expect. Prior studies have showed similar results with hypertensive subjects, and they had similarly high velocity ranges in their elderly subjects. Lastly, we saw a consistent difference in in pulse wave velocity between expiration and inspiration across the entire age spectrum. So future work will, of course, necessitate validation and reproducibility studies. Additionally, we also would like to explore the difference between our cardiac gating. This work was a tag onto a cranial study, which used pulse oximeter gating. However, there's a physiological delay between pulse oximeter and ECG gating, and this affects our measured time shifts, so we need to explore that further. And yeah, I'd like to thank all of our co-authors and collaborators, and thank you for listening.
Thank you very much for this presentation. There is a question by Daniel.
Very nice work, thank you. I was just wondering, pulse wave velocity is extremely sensitive to the chosen temporal resolution, but also to other artifacts like background phases, etc.
Right.
I don't know, have you noticed that? Or
Yes, that's something that we've explored. Our temporal resolution for radio sequences is around 30 milliseconds. We're also acquiring Cartesian sequences too. Those are a little lower. But we have noticed differences, and we've had some difficulties with measuring adjusting the temporal resolution. We have to do some interpolation to compare the different sequences. Background phase correction is something that we've also explored doing with and without. So yeah, it has affected our data, and there's, I'd say, more to be done in comparing those.
Thank you, great presentation. I think you very nicely showed that there's many ways to calculate pulse wave velocity, particularly to determine the timing difference. Can you comment a little bit on why you choose the time to foot and how the results of the time to foot differed from the other three methods that you showed? And second question is, even with time to foot, it sounds like you had to include a number of cases because the results were non-physiologic. And do you think that's related really to the pulse gating because you didn't have the exact timing of the R wave?
Yeah, so for the first part, let me just clarify, you're saying what did we notice the differences between the different...
Yeah, between the four different methods that you have, you chose time to foot, but if you were to compare the results to the other three, I don't know if you have the data, how different are they?
Yeah, so we do have the data for all of those, and that's actually something that we're exploring further, reading a separate abstract on that actually. We chose time to foot in this case because, well, between the four, for example, time to point is just, it looks at a single point in the flow waveforms, and so while we had the most successful subjects with that, I believe 102 subjects, we only had to exclude 8. It's a single point, and so you're more susceptible to sampling error between those. Cross correlation uses the entire waveform, but we actually, the statistical significance of that result was very low. So we felt that time to foot was sort of a happy medium in between those. I think there's still a lot more room for exploration in between those methods, and there's other methods that are being developed, and so there's a lot of room for improvement. And the second part of your question was, I'm sorry.
More to the gating, if you think that if you had EKG gating, that maybe some of these errors would go away.
Yeah, I think ECG gating is something that we are strongly hoping. Actually, I believe we're beginning to implement that. We're still collecting more data, and I believe we've recently switched to ECG. And so timing issues between the sequences, we're acquiring 2 successive axial slices. These slices are not acquired at the same time, and so because of that, there is some delay between that. Maybe the heart rate changes. And those have definitely, I believe, affected some of our analysis and are one possible cause for the error, the unphysiological values that we're seeing in some of these cases.
Thank you.
Thank you very much. We move on to the next speaker.
Our next speaker is Austin Keeling. She's from Northwestern University. And the title of his talk is about 4D flow MRI derived to regional aortic wall shear stress in COVID-19. Please.
Thank you. Hi, everybody. I'm going to talk about our study on 4D flow MRI derived regional aortic wall shear stress in COVID-19. If we start with the potential effects of COVID-19 infection on the cardiovascular system, we know that it's a complex multisystemic process, and extensive cardiovascular involvement may occur with complications in acute phase and also in the prolonged infection. During the acute phase, we may see myocardial infarction, arrhythmia, and pericarditis are some of the effects of the COVID infection. And during the chronic phase, we may see systemic vascular function problems and also higher arterial stiffness, and large vessel vasculitis are some of the effects of the COVID-19 infection on the cardiovascular system. We know that 4D flow MRI is a non-invasive MRI technique which allows us to measure 3D blood flow velocity and visualize the temporal evaluation of the blood flow. We can also quantify several hemodynamic parameters, including forward flow, reverse flow, peak velocity, flow stasis. Pulse wave velocity and wall shear stress are also some of the parameters we can measure through 4D flow MRI. We investigated wall shear stress in this study. So what is it exactly? It has been defined as the tangential force of the flowing blood on the vessel, and it's a known contributor to the arterial medial wall degeneration and also vessel wall remodeling and also atherosclerosis. So the purpose of the study was to investigate if the 4D flow MRI-derived regional aortic wall shear stress is altered after the COVID-19 infection. So for this purpose, we included 37 COVID-19 cases and 37 healthy volunteers in this study. The mean age of the patient group was 56, which was 46 in the volunteer group, so there was a mean age difference between the groups. Out of 37 cases, 36 patients were admitted in the hospital, including 7 intensive care unit admission, and 1 patient was managed as an outpatient. The average time between the initial COVID-19 diagnosis to the 4D flow MRI scan was 184 days in the patient group. All patients underwent compressed sensing accelerated coronal 4D flow MRI of the chest, and volunteers were scanned with the GRAPPA, traditional GRAPPA accelerated 4D flow MRI. The regions we measured the wall shear stress in the aorta were entire aorta and also ascending aorta, and we did the measurements on the aortic arch as well. And we did the comparisons between the entire group of the patients and also volunteers, and also in the subgroups of specific age groups, such as 20 to 50, 50 to 70, and also age and gender matched subgroup. T-test was used for the group-wise comparisons, and we also measured the correlations of the 5% peak velocity, voxel-wise peak velocity, and 5% wall shear stress in the entire patient group. The pre-processing of the 4D flow MRI data included automated phase offset correction, noise masking, and unaliasing. And then we did the 3D global entire aorta segmentation, which was performed automatically in the patient group and manually on a designated software in the volunteers. Here we can see a 3D segmentation of one of the COVID-19 cases. And the same segmentation method was also applied for the ascending aorta and aortic arch as well. Wall shear stress measurements, it was interpolated from the local velocities and reported as the average of the top 5% during the 5 systolic phases for each subject. We also calculated the voxel-wise 5% peak velocity and the average of the maximum top 5% of the velocities was reported. Here we can see wall shear stress measurement of one of the cases again. In the ascending aorta, we can see the region with higher wall shear stress and the wall shear stress histogram as well. When we look at the results in the entire aorta, the wall shear stress levels in the patient group and volunteers did not show any significant difference in all groups, including the entire aorta and also the subgroups. And the box plots represent the results for the entire cohort and age and gender matched subgroup specifically. Similarly, in the aortic arch, we did not see any significant difference between the patients and volunteers in the wall shear stress results for the entire cohort and subgroups as well again. However, when we looked at the ascending aorta, the whole cohort, entire cohort of the patients had lower wall shear stress results levels compared to the volunteers, and similarly the ages between 50 to 70 and age and gender matched subgroup also had significantly lower wall shear stress levels compared to the volunteers. For the group of 20 to 50, the patients also had lower wall shear stress results, but the result wasn't significantly different from the volunteers. The next step was the voxel-wise peak velocity measurement, which was also compared between the patients and volunteers in the entire aorta, and this was also significantly lower in the patient group compared to the volunteers. And the last one, the last parameter, last analysis we did was the correlation between the peak velocity, voxel-wise peak velocity, and the wall shear stress. And we observed significant positive correlation, more than 90% correlation between the two parameters in the patient group. So in summary, we know that COVID-19 has several effects on the vascular system, but its impact on the aorta hasn't been well described so far. Our results showed significant reduction of wall shear stress in the ascending aorta in COVID cases compared to the volunteers, healthy subjects. But the underlying reason for this difference is not clear yet. The feature work for this study should include looking at the baseline aortic diameter in the patient group and volunteer as well to see if there is any difference, which is currently something we are working on. And the pre-existing risk factors for the cardiovascular problems such as hypertension, diabetes, age and gender differences should also be considered in the analysis. Blood pressure and medications patients are taking at the time of scan should be also reported. We need to confirm these results in larger cohorts, and we need to follow up these cases to explore COVID-19 impact on the aortic growth and also other adverse events on the cardiovascular system. Thank you.
So this abstract is open for questions.
So, as I understand it, your control group is just a control group who has not had COVID, and I don't know how
No COVID, no other.
So they were
any
tested,
cardiovascular
no
disease,
antibodies,
nothing.
nothing. But
Antibodies for COVID? Are you asking? No,
Yeah,
we
well,
didn't check that for
you
the.
didn't check. So, I mean, most of us in this room will have had COVID or have been vaccinated against COVID by now, I would have thought. But also your patients were patients who were hospitalized with COVID-19, and we know that those that were hospitalized were more likely to have hypertension, pre-existing cardiovascular disease. So you need to match your controls. Your controls need to have the same hypertension, the same cardiovascular disease, the same instance of diabetes, etc., to be a true control group.
Yes, the other analysis we did was, so 7 patients out of 37 patients had hypertension in the patient group. We tried to compare the wall shear stress between patients with hypertension and no hypertension. We didn't see any difference, but healthy controls didn't have any disease.
As I say, the problem is that they are healthy,
Yes.
whereas the patients who go into hospital were probably not healthy before they got the COVID. They had comorbidities, which is why they ended up in hospital.
Mm-hmm.
Yeah.
Thank you.
Okay, thank you. Maybe we should move on. Thank you.
The next speaker is the organizer of this meeting. So this is Hideki Ota, and he will talk about rapid 3D KY, KZ-centric FFE thoracic MR angiography using real-time, real-time motion correction.
Yeah, thank you. And thank you for kind introduction. So my talk is about the rapid acquisition of thoracic aortic MRA, thoracic MRA. And here's my disclosure. I have a research grant from Canon Medical Systems. So generally, the thoracic aorta is acquired in a product type using fast field echo with respiratory gating or diaphragm navigator echoes using real-time motion correction. So the total scan time depends on the efficiency of subject diaphragm motion range, and it may often take a long acquisition time. And past study introduced the 3D-centric KYKZ FFE acquisition with improved acquisition efficiency in wide range, the 30 millimeter navigator echo range as compared with conventional sequential acquisition with narrower 5 millimeters, for example, or navigator echo range. So this is just a simple schema of the conventional method using narrower navigator bands and proposed one. So with even if there's, we can combine the shifting of the slab and wider acceptance range, then we can efficiently acquire the images. But the further reduction of the scan time may be achieved with high resolution deep learning reconstruction while keeping reasonable image quality. So the purpose of this study was to develop time-efficient, high-resolution tracking MRA and compare it with conventional 3D FFE MRA. The time efficiency could be achieved by the two approaches. One is about the image acquisition. The second is the high-resolution deep learning reconstruction to compensate the image quality. In this IRB-approved prospective study, we enrolled a total of 15 healthy adult volunteers with the mean age of 55. And these are case-based trajectory schemes. The standard FFE acquires one slice encoding per TR, whereas this concentric KYKZ acquires multiple slice encoding in central KYKZ per TR without correcting the peripheral part of the K-space. Asymptomatic Fourier imaging is used in phase encoding direction. The contrast determined time of the standard and the proposed method is indicated in yellow, respectively. Here are image acquisition parameters. The proposed method resulted in 70% reduction of the sampling. The slice thickness was 1.7 millimeter, and the number of slices was 18. As I said, the real-time motion correction band was set at 30 millimeters. And these are scan times shown here. So this is the high-resolution deep learning reconstruction process pipeline. The pipeline is briefly separated into two blocks. The first neural network process is a denoising block for reduction of the noise signals. The acquired K-space data is transformed to a complex image with coordinator, combined and Fourier transform. The complex valued image is input to the first neural network for denoised images. The second neural network here in pink is an upsampling block for higher resolution. The denoised images are enlarged and zero field. Zero field interpolation was performed with the deep learning reduction of the noises in that process to provide higher resolution images. So here's the image quality evaluation we did in visual evaluation, evaluated by the two radiologists, including me. And then we measured the quantitative evaluation, which was the coefficient of variation in the aortic root, as well as the contrast ratio of the aorta to the myocardium. So statistical analysis was a kind of standard method, and p value of 0.05 was considered as statistical significance. Here's the results. So real-time motion correction with 30 millimeter threshold allowed for 100% efficiency in correcting all echo signals. And so we just compared the conventional FFE with regular reconstruction and 3D centric KYKZ FFE with higher resolution deep learning reconstruction. So we can imagine that the image quality score was significantly higher in the proposed method. And also the coefficient of variation was smaller in the proposed method. But regarding the contrast ratio didn't show significant difference or almost similar between the two acquisitions. So this is one case presentation. The left side here is conventional FFE with regular construction. We can appreciate the artifact probably from the breathing, the motion artifact. And this kind of artifact could be weakened, diminished, or less dominant in the proposed methods. And then in this applying high resolution deep learning reconstruction, we can now clearly see the delineation of the large vessels as well as the significant reduction of the noises. Sorry. Okay. And this is what the NPR image. So we can appreciate the proximal parts of coronary arteries of the both right and left side on all the images, but you can also appreciate the improved image quality with the high resolution deep learning reconstruction. So, this proposed method with 100 efficiency in real-time motion correction combined with the high-resolution deep learning reconstruction provides good image quality of the thoracic aorta within very short time of scan time. So, of course, there is a limitation about no acquisition of real patients in this study, but this proposed method has the potential to improve the clinical workflow. Thank you for your attention.
Thank you very much for this very interesting work. Is there anybody with a question? We would have time for one quick question. Right, I have a quick question, otherwise. I'm always observing with super resolution or with algorithms trying to match the real resolution that the images are much less noisy, which is nice, but they're also getting a little bit more blurred. You're getting more details because of the less noise, but I feel like the edges become a little bit blurred. Did you look into that? Did you find anything?
So far, in this small cohort, we didn't see so much problem about that. Yeah.
Okay. All right. Thank you. And with this, we move on to the next speaker.
Yeah, our next speaker is Anthony Marron, and he's from Northwestern University. The talk title is about the scan protocol reproducibility of 4D flow MRI-derived global aortic pulse wave velocity.
Thank you for the introduction. Hi everyone, my name is Anthony Maroon and I'm a research fellow at Northwestern University. My study is on the reproducibility of 4D flow MRI-derived global aortic pulse velocity using different 4D flow MRI protocols. I have nothing to disclose. So as we know, pulse velocity is a biomarker used to measure arterial stiffness, which is seeing increased clinical adoption. In fact, evidence in recent years has shown that pulse velocity not only progressively increases with age as part of the normal aging process, but also holds prognostic significance. Specifically, pulse velocity is notably elevated in patients who are at high cardiovascular risk and can serve as a predictive metric for future cardiovascular events, strokes, and all-cause mortality. By definition, pulse velocity is the speed at which a pressure pulse generated in systole traverses the vasculature. It can be measured using different techniques such as ultrasound or 2D phase contrast MRI, but clinically it is frequently measured using applanation tonometry at the carotid and femoral arteries. While this technique is widely used, it provides an overall assessment of the arterial system from the large arteries to the periphery and cannot provide a local measurement. In contrast to traditional methods, 4D flow MRI is an imaging technique that assesses 3D blood flow velocity and allows local pulse velocity measurement, such as within the aorta. Not only does it provide these local measurements, but 4D flow MRI also has several additional advantages, specifically by quantifying blood flow velocity across all 3 spatial dimensions within a volumetric coverage. It enables a retrospective analysis of any imaging plane within the 3D volume through automatic and accurate plane placement. This capability makes it superior to alternative techniques like 2D phase contrast MRI and Doppler ultrasound, which, despite offering a higher temporal resolution, they necessitate careful planning and manual plane placement. Additionally, 4D flow, due to its comprehensive 3D volumetric coverage, it allows for the placement of numerous planes for quantification, which reduces any misestimates induced by noise on a specific plane. And lastly, 4D flow MRI offers the capacity to conduct a 3D segmentation of the aorta and calculating a central line, which results in a more precise calculation of the distance between planes. Initially, studies on pulse wave velocity from 4D flow MRI were conducted on a tailored aortic MRI protocol. This protocol consisted of a narrow sagittal oblique acquisition focused on the aorta and included respiration control by navigator gating. Although this protocol has been used for several years, it does not include the heart and surrounding vessels, and also being navigator gated, it requires time-consuming pre-scan planning. For this reason, in large academic centers, there has been a shift from an aortic 4D flow protocol to a whole heart protocol. This protocol is one that covers the entire chest and is free breathing, which means that it can provide a more comprehensive evaluation of cardiovascular hemodynamics by including the heart and surrounding vessels, and is also more easily implemented into existing clinical protocols. But despite this increased adoption, the reproducibility of pulse wave velocity using whole heart in comparison to aortic protocols has not been evaluated yet, and therefore the aim of this study was to assess the robustness of pulse wave velocity measurements obtained using these 2 protocols, and second, to examine the reproducibility of the well-established correlation between pulse wave velocity and age. So we retrospectively included 38 healthy controls who underwent a research cardiothoracic MRI, which included a back-to-back respiratory navigator-gated sagittal oblique aortic 4D flow MRI, followed by a whole heart 4D flow MRI with respiratory gating. We also retrospectively included 9 BAV patients who had these 2 acquisitions. 4 had the acquisitions acquired back-to-back, while 5 had a time interval of up to 9 months between the 2 scans. But all BAV patients were clinically stable and did not undergo any surgery during this follow-up, during this interval, or even afterwards. In our analysis, we combined both BAV patients and controls into one group. All 4D flow MRI scans were acquired using 1.5T MR systems, and you can see here the scan parameters for the 2 protocols. And I would like to highlight that the temporal resolution and rank were the same for both. For patients and controls, aortic and whole heart 4D flow data were manually processed to correct for phase offset, noise, and velocity aliasing. A phase contrast MRA was then generated and used to perform a manual segmentation of the aorta. From this segmentation, a center line was generated and orthogonal planes were placed across the aorta using an interplane distance of 3 millimeters. The flow waveforms were then acquired, and pulse velocity was calculated using the cross-correlation technique. A total of 47 subjects were analyzed, and the average pulse velocity from the aortic protocol was 6.8, and it was 7 from the whole heart protocol. And on the Blount-Altman analysis, the bias was not significant, and there was a good agreement between the 2 with a % difference of 25. Now moving on to the association between pulse velocity and age. On this plot, you are seeing in blue the results for the pulse velocity from the aortic protocol, and in red the results for the whole heart protocol. Circles represent controls and triangles are the AV patients. And we saw that there was a similar correlation between age and pulse velocity in both protocols, and that pulse velocity increased by 1 meter per second every 10 years. In addition, when looking at the BAV patients, we also noticed that BAVs do not exhibit higher pulse velocity compared to controls, and that their pulse velocity followed a similar trend to controls. So in conclusion, in this study where we assessed the agreement between aortic and whole heart 4D flow MRIs for quantifying aortic pulse velocity, we did not see a significant difference between the 2. This agreement was comparable to previous reports that evaluated retest reproducibility of a single aortic 4D flow MRI protocol. In addition, the association between pulse velocity and age was similar in both protocols with an expected rise of 0.1 meter per second per 10 year. And these findings align with prior reported estimates of pulsar velocity trends in normal aging populations. And finally, pulsar velocity in BAVs were closely aligned with healthy controls, which is consistent with growing evidence indicating that BAVs do not experience an increase in aortic stiffness. However, our study was limited by small sample size, so future work should focus on acquiring larger data sets as well as expanding the analysis to include patients who exhibit elevated pulsar velocity, such as those who have cardiovascular risk factors. And with that, I would like to thank my lab for their contributions to this study, and thank you all for your attention.
So, any question from audience? Yeah, I have a very short question about this. From your results, we find there is an age correlation with positive velocity, but from two of your technique, you can have two positive velocity from two acquisition. So have you do the correlation test between these two techniques?
No, we did not. We just...
yeah, but for the reproducibility study, I think the correlation between two techniques is most important.
Yeah. We did the Blount-Altman analysis between the two, and we did not see a significant difference, but we did not explore the correlation between the two when it comes to the correlation between pulsar velocity and age.
Yeah,
but that's definitely something worth doing.
Thank you.
Thank you.
Right, thank you. We will move on to the next speaker. This is Ludovica Romanina. I'm sorry. You will talk about Simbatone, a data-driven reconstruction using pilot tone navigation for free running CMRA.
Thank you for the introduction. Okay. So yeah, I'm Ludovica Romanin. Thank you for having me today. So I will focus mostly on CMRA. Traditionally, state-of-the-art CMRA works that it's ECG triggered and navigator gated so that you correct for cardiac and respiratory motion. But you can also perform MRA using free running. So the idea here is that data is acquired continuously, and then the motion correction is performed retrospectively using self-gating readouts that are continuously acquired in an interleaved fashion throughout the acquisition. And so you use these basically to extract cardiac and respiratory phases and have a whole 3D volume in all the different physiological phases. So the way that we do clinically the workflow for running data acquisition is consisted of first you acquire the data in this simple and one-click way, and then afterwards you reconstruct the data retrospectively. It's only done offline and it takes quite a few hours. So in order to improve the translation of this clinically, we have an online scanner reconstruction that is called SIMBA. So this is a similarity-driven multidimensional binning algorithm. It takes less than a minute and it allows to visualize the cardiac anatomy in 3D directly at the scanner. So in combination with ferumoxytol injection, this is quite successful, especially in the visualizing the anatomy for congenital heart disease patients and in pediatrics. However, when we try to translate the same type of workflow in non-contrast data, we experience less robust results with SIMBA compared to what we have with ferumoxytol. So the goal of this project is to use, instead of the SI profiles to extract motion, the pilot on navigation that is not affected by the MR acquisition, but is completely independent, so that we can first obtain similar results to what we had with ferumoxytol, and then translate this to non-contrast data so that we have more robust image quality. So the workflow for the SIMBA reconstruction, you start with a free running acquisition, you extract the same SI profiles that you would for self-gating motion correction, and then you concatenate this into a single matrix that is basically representative on the underlying motion. You reduce it in dimension to extract only the features that are important for motion correction, and then you cluster this information into different groups so that you obtain a volume that is not blurred by motion. It allows to visualize, even by doing a simple 3D gridded reconstruction, the cardiac anatomy in a sharp way. So here we are bound with the sampling of the SI because the temporal resolution defines also the data that we cluster together. So when we move towards using pilot on navigation with this Simbatone approach, we extract the piloton signals that is acquired concomitantly with our free-running acquisition, and this is basically representative of one single time point associated to a time point of our acquisition. So when we perform the same dimensionality reduction and clustering, we can have a precise selection of data points that are acquired throughout the scan. So we tested this approach in two different cohorts, one of patients after the injection of ferromoxetol. So these are 6 congenital heart disease patients that were acquired with a GRE acquisition and still with the same trajectory. There is a 3D radial phyllotaxis trajectory. And then in the non-contrast data, that is in a volunteer cohort, we have only 4 subjects. This is a fast interrupted steady state for native fat suppression, so that overall both cohorts have scans that last around 6 minutes. And both of these were acquired on a 1.5T system. So we compared the results in terms of image quality metrics, both lung, liver, and blood myocardium sharpness, and after segmentation of the right and left coronary vessels, we computed the visible length and sharpness. So these are some examples of a ferromoxetol data set. We can see that the image quality is comparable for both SIMBA and Symbaton results in terms of overall anatomy, and both images are diagnostic. We do have better visualization of the coronary arteries with the original method compared to Symbaton in this case. It may also be due to the selection of the cluster that we have in this particular case, but both images are diagnostic. And then for the non-contrast example, this is a FIS data set of a volunteer. We see that in this case, the benefit of using Symbaton is higher. We have better delineation of the cardiac anatomy, especially of the papillary muscles and of the myocardial wall. And if we apply some comprehensive to account for the very undersampled acquisition, we can even have a very good delineation of the coronary arteries, and which are much more visible using Symbaton compared to SIMBA. So to summarize our findings, in this work we were able to adapt the same SIMBA method instead of using SI profiles to using piloton. This allowed us to have not only good image quality with ferromoxetol enhancement, but also non-contrast data sets. Of course, this is just a preliminary study. We have some limitations regarding the selection of resting phases using piloton because of the information that is encoded in the SI profiles is much higher compared to the 1D signal, especially we have spatial information in the SI profile that we don't have in the piloton. And then also smaller, noisier elements in the piloton signals that we don't filter out may completely bias our clustering. So this is also something we need to take into account for future work. And of course, we need to test in larger cohorts to further ascertain the benefit of this reconstruction and its potential to be sequence independent and independent of the underlying contrast. So to conclude, we demonstrate the potential of Symbaton as a fast and data-driven reconstruction of free-running data that can be sequence independent for different contrasts and different sequences. Thank you very much for your attention.
Thank you very much. This is really very nice work. Do we have a question from the audience? So my question would be, how did you implement the Symbaton on the scanner? Is this like an additional piece of hardware that you have it running on, or?
For the moment, I haven't worked on the inline implementation. There's been quite a lot of work regarding the inline implementation of piloton signal processing, so I will probably build on that to have my own reconstruction.
Yes, so that means you're currently doing it offline.
I do it offline, and still takes it's still very fast, so it's just a matter of doing some troubleshooting to have it in line. Yeah.
So it would pretty much run on a normal computer with a normal processor?
Yes, yeah. It's just a matter of having the reconstruction framework, but this can be done. It should be working in line as the other one. Yeah.
Yes, very nice. It's very nice work. Thank you very much.
You.
We are going to the next speaker.
So our last speaker for scientific oral presentation is Umer Ramzan. He's also from Northwestern University, and The talk title is Association between Ascending Aortic Hemodynamics and Ascending Aortic Clearance.
Yeah, hello everybody. My name's Umar. I'm a medical student at Northwestern, and yeah, I'll be talking about the association between ascending aortic hemodynamics and ascending aortic length. So just to give a bit of background information, thoracic aortic aneurysm is a relatively uncommon condition with about 5 to 10 incidents per 100,000 person years. And the most common type is ascending thoracic aortic aneurysm. And although this is an uncommon condition, it's been increasing in recent years due in part to better imaging, more frequent imaging, and an aging population. It's a dangerous condition due to the risk of aneurysm rupture and acute type A dissection. And it's been estimated that up to 22% of patients die before even reaching the hospital when experiencing a complication of thoracic aortic aneurysm. So it's important to be able to identify these patients and to intervene when necessary. The current guidelines for intervention revolve around measuring aortic diameter, and these guidelines have been estimated to miss up to 60% of patients that are at risk of acute type A dissection. Recent research has shown that ascending aortic length and ascending aortic hemodynamic parameters may be more promising tools by which to identify these thoracic aortic aneurysm patients that are at risk of acute type A dissection. However, there's very little data for how ascending aortic length and ascending aortic hemodynamic parameters relate to each other, and understanding that relation could be very helpful and valuable in creating new and improved guidelines for intervention for these patients. As such, our research sought to explore the relationship between ascending aortic length and ascending aortic hemodynamic parameters. So in order to do this, 107 patients were recruited with tricuspid aortic valve and no relevant surgical history, who also previously had a 4D flow MRI performed. The average age was 62 years and 24 patients were women. The data was automatically pre-processed using a deep learning approach. 3D segmentation of the thoracic aorta was then generated, and the aorta centerline was automatically calculated, and an example is shown on screen. The ascending aortic length was measured by manually selecting 2 planes along the centerline. So the first plane was placed at the sonotubular junction, and the second, more distal plane was placed just proximal to the brachiocephalic trunk. 2D analysis planes were then placed automatically along the centerline of the ascending aorta at intervals of 1 millimeter, and the unit normal vector was calculated at each plane in order to define forward and reverse flow. So this table shows all of the hemodynamic variables that we measured, as well as how we measured them. For mid-ascending aorta diameter and sinus of Valsalva diameter, we use standard of care MRA. For the aorta volume, we derive that from the aorta segmentation. For kinetic energy, we assess that through making measurements over each voxel along the ascending aorta. For flow stasis, we assess that through generating volumetric stasis maps. For the maximum velocity, we selected the time point which had the highest 95th percentile voxel-wise velocity, and then the maximum velocity was defined as the average of the maximum top 5% velocities at that specific time point. And then forward flow and reverse flow were assessed through projecting blood velocity onto the reverse and forward unit normal vectors. So Pearson correlation was performed between the ascending aortic length and the hemodynamic variables that were previously mentioned. And in addition, the patients were split into 2 groups. One group had ascending aortic length greater than or equal to 100 millimeters, and the other group had ascending aortic length less than 100 millimeters. And t-test was performed between these 2 groups in order to compare the hemodynamic variables. So here are the results of the Pearson correlation between ascending aortic length and the hemodynamic variables. Here's the same data with all the statistically significant correlations. So as you can see, correlation was significant between ascending aortic length and mid-ascending aorta diameter, sinus of Valsalva diameter, aorta volume, average kinetic energy, average flow stasis, average maximum velocity, average forward flow, and total reverse flow. And then here are the results of the group-wise comparison between the ascending aorta length greater than or equal to 100 millimeters group and the ascending aorta length less than 100 millimeters group. And here's the same data with the significant comparisons highlighted. So comparison was significant for sinus of Valsalva diameter, aorta volume, average flow stasis, average maximum velocity, average forward flow, and total reverse flow. So as previously mentioned, there's currently a lack of data for how ascending aortic length and ascending aortic hemodynamic parameters relate to each other, and our results indicate that ascending aortic length may be associated with a variety of hemodynamic parameters. And as previously mentioned, the current guidelines of using aortic diameter as a proxy by which to determine when to intervene in these patients is not sufficient, as a significant portion of patients are missed. And so hemodynamics and ascending aortic length may be more reliable tools for this purpose. But as such, it's important to understand the relationship, as this may lead to better identification of patients that are at risk of complications of ascending thoracic aortic aneurysm, and may also help in creating more effective intervention guidelines for these patients. Thank you.
So this talk is open for question.
Thank you so much. It's interesting. But what do you think about the ascending aortic lengths in different height? If you have a woman with 1.50 meters and a man with 2.10 meters, what about the aortic length?
Yeah, so from what I understand, the study is kind of looking at the change in aortic length as the aneurysm evolves. So looking at some of the literature, it indicates that as the aneurysm evolves, there's a change in aortic length. And then there's certain breakpoints that are associated with that. So for example, some papers have cited that a breakpoint between 110 to 115 millimeters may be associated with a greater increase. And then same with 125 to 130. But that's a good point, considering that that specific paper only cited those two breakpoints, whereas it may be more variable according to gender differences, height differences, so yeah.
Okay. So let's move to next speaker.
Yes, we are moving now to the power pitches for the posters, and these, to my knowledge, are maximum 3 minutes. I think 2 minutes, 1 minute discussion. And the first speaker for that is Armando Barrera, and he will talk about the comparison between 3D deep learning and velocity-based level sets aortic segmentation in 4D flow.
Thank you. Hello everyone, my name is Armando Barrera. I will show you my work on comparison between 3D deep learning and velocity-based level set aortic segmentation in 4D flow MRI. This work has been done in collaboration with the hospital center in Dijon, France, and also at company Cassis, which is a specialized cardiovascular imaging software company. So, as the presenter before said, thoracic aneurysm is a cause of, has been the cause of 10,000 deaths in 2019. Is very asymptomatic. It is very difficult to prevent, and this is part of our research in Cassis. The evaluation of a thoracic aneurysm is based on the diameter of the vessel, and this parameter is very difficult to assess due to the morphological and physical factors of the patient. In order to do the research on this topic, we use 4D flow MRI, which allows us to compute hemodynamic parameters such as kinetic energy loss and Walsh stress. But some of these parameters are difficult to assess if a segmentation is not precise. And this is why we focused on this topic of comparing traditional segmentation based on imaging techniques and deep learning segmentation. So in this comparison, we use 36 patients with thoracic aortic aneurysm, and we only use one frame of cardiac cycle. the systolic phase was used in order to generate the segmentation. So the level set segmentation is based on discontinuity of the vessel, and we use a generated MRI image in order to propagate the vessel boundary. For the deep learning segmentation, we use a typical 3D unit architecture with 4-level encoder-decoder structure and skip connections in order to maintain spatial information. So to evaluate the results of both segmentations, we used a merging of manually segmented aortas of the 36 patients, and we use a DICE score and house of distance to assess the efficiency of these segmentations. We also computed Warshey stress in order to compute the results of these segmentations in a real case. And so we saw that UNet approach provided better results as in for DICE score and house of distance. But for the computation of Warshey stress, the level set segmentation is and provide better results.
Your time is up. Oh,
yeah.
Okay.
So this approach gave us 3 main lines of discussion, which is the first one, the high potential of deep learning in segmentation of the aorta, but also on other vessels, and the possibility to extend the model to perform 3D plus time segmentation. Also, we are looking into the possibility to do a combination of anatomical images and velocity images to perform segmentation of the aorta. Thank you very much.
Okay. Because you use up all the time, so we need to move.
I just wanted to say, if you have any questions, we have a booth in the 6th floor, so you can go and ask questions.
Okay, thank you.
Thank you.
So our next speaker is Devi Dushfonia, and he's from Northwestern University. The title is Robustness of 4D flow MRI-derived aortic Warshey stress in healthy controls and in patients with BAV, please.
Yes, thank you for the introduction. Hi, my name is David Dushfonia. I'm going to be presenting about the robustness of 4D flow-derived Warshey stress in a cohort of control subjects and patients with bicuspid aortic valve. So briefly, 4D flow-derived Warshey stress is a reproducible and reliable imaging biomarker that may predict aortic complications. And traditional 4D flow Warshey stress studies were done on aorta-targeted acquisition protocols that offer great aortic spatial resolution. And the newer protocols like whole heart acquisitions offer coronal acquisition that allow comprehensive assessment for the entire cardiac chambers and the neighboring vessels. However, the reproducibility of Warshey stress across the 2 protocols have not been assessed, and this is the aim of this study. So for the methods, we included 38 control subjects and 10 patients with BAV, and they were all 4D flow scans were pre-processed, and the aortas were manually segmented. And Warshey stress was derived for the ascending aorta and arch by selecting a region of interest. And on the top right, we see a histogram, and we calculated the median and the maximum Warshey stress, and we compared that using Land-Altman plots for the 2 protocols. Next, for the BAV patients only, we registered the segmented aortas onto a Warshey stress average cohort of at least 10 age and sex matched control subjects, and in the bottom right we derived a heat map, which is a geographical kind of depiction of the areas of elevated, similar or lower Warshey stress, and this is according to the calculation of that outside 2 standard deviations of the control that it's abnormal. Next week, we calculated the relative area of elevated wall shear stress for the ascending aorta and arch by selecting a plane for that region, and we compared the results for the two protocols. So for the results, for the blend ultimates for the median and maximum wall shear stress, I displayed those on the poster, which I'm happy to take questions at. We showed the good agreement between the median and maximum wall shear stress for the two acquisition protocols. And in regards of for the heat map comparison, so on the right we have the sensitivity analysis. So when we calculated it for the two standard deviations to consider the wall shear stress abnormal, we noticed that the results were not optimal. So we derived the whole heart wall shear stress calculations across different standard deviations to consider the output as abnormal. So we did that for standard deviations of 1 to 2.5 and compared that to the ground truth, the aorta targeted derived wall shear stress. And we were able to identify a threshold of 1.5 to whereby the...
You need to speed up.
Yeah, one second. So we were able to identify the standard deviation of 1.5 for the whole heart derived calculations that most closely resemble the aorta targeted calculations. And here we have a visual representation on the left of how varying the standard deviation would affect this heat map. And I'd like to thank my collaborators and my team for helping with this project and all others. Thank you.
Okay, thank you. So 3 minutes is very challenging.
All right, so we're coming to the next last 3 minute. I remind everybody, 3-minute talk by Akio Inage. Hemodynamic analysis of the pulmonary artery for congenital right side heart disease in adulthood by 40-flow MRI.
Using 40-flow MRI, we evaluated hemodynamics in the pulmonary artery of congenital right side heart disease in adulthood. In 20 adults, we measured energy loss and helicity of the main pulmonary artery by cardiovascular MRI. The maximum value in one heartbeat and the total value were obtained for energy loss. Helicity was defined as a vector quantity with clockwise rotation being positive and counterclockwise rotation being negative, and the total value was calculated. As for the analysis method, we traced the area from the pulmonary valve position to the right and left pulmonary artery bifurcations while looking at both the 2D SSP senior image and the phase image and calculated the energy loss and helicity. 40-flow MR imaging were analyzed with IT-flow. The mean age was 27 years. The cases included 15 cases of postoperative tetralogy Fallot without pulmonary arterial hypertension and 5 cases of congenital heart disease with pulmonary arterial hypertension. Peak energy loss, time to peak energy loss, and total helicity were higher in the CHD-PH group than TOF group without significant differences. Peak energy loss value was significantly higher during systole, but were observed during diastole in 8 patients. The combined mean value of helicity was positive, with clockwise predominance in 12 cases. A strong correlation was found between peak energy loss and clockwise helicity and counterclockwise helicity. In addition, a correlation was observed between diastolic energy loss divided body surface area and diastolic clockwise helicity and diastolic counterclockwise helicity. A correlation was also observed with the pulmonary regurgitant fraction. In conclusion, in this study, helicity in the main pulmonary artery was dominant clockwise in congenital right side heart disease in adulthood. It was suggested that energy loss was involved in helicity throughout the entire cardiac cycle, and that peak energy loss had a particularly large effect. Thank you for your attention.
Thank you very much. Yes, we have to conclude, unfortunately. Thank you for coming.
Okay.
We have
Thank
to
you very much.
Yeah, we have to conclude the session. This was a very interesting session, and I thank everybody for every presenter for their nice presentations. And please go to them and talk to them in case you have still questions left. We have a lunch break now, and we will come back for the next session at 2:15.